today on the Diabetes Podcast.
And as a medical community, we've definitely failed our caregivers. We're not putting enough resources into focusing on our caregivers where we should, because if our caregivers aren't taken care of, then our patients are not taken care of. I'm not saying physicians should run on hospitals, because if you're a physician that does not have business expertise, you shouldn't be an administrator. But if you're an administrator who has never taken care of a patient, you have no right making decisions.
Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, we're in for a real treat today. Today we are joined by Dr. Golnosh Sharafsaleh. She's board certified in geriatrics and lifestyle medicine. Dr. Sharafsaleh, welcome to the podcast.
Thank you so much. And it is a pleasure to be on your podcast.
Yay, I'm so excited. I want to dive in because I notice with one of the biggest risk factors for type 2 diabetes is over age 65, which absolutely falls in your specialty. And what I see occurring very often is people's regimens by this time for their blood sugar management have gotten more complicated, oftentimes involving insulin. And at the same time, the relationship between type 2 diabetes and dementia is really high, and hearing loss is higher. And then the relationship between hearing loss and dementia come into play. So I would love your experience with people who have type 2 diabetes. I know it's a very loaded question, but kind of what your biggest concerns are in the population that you see who also have diabetes and advanced age, and who you see do better versus those who kind of struggle. Like, I have so many questions, so I can't wait to get into this.
Amber, this is an exciting topic because you even said hearing loss, but I think there are so many more dimensions to this, especially with my patients because of the cardiovascular and metabolic complications as we age. And you said hearing loss. Yes, there's this bidirectional, but there is like a tridirectional as with vision loss as well, or maybe quadruple dimensional, because then we think about cholesterol and LDL control and how that is related to diabetes. So for so many years, I think we have been treating diseases in silos, like in isolation. Yes. Mm-hmm. Although we are a holistic being. And in geriatrics, we think about people, not just one organ system. We really think about the whole person when we take an approach to treatment. And it's not even just medical, but we think about, okay, what matters to you and where is your mindset at, whether that is a mental disorder or cognitive dysfunction. We think about medical problems and how those medical problems interact with each other, with medications. So then we think about medications, drug-drug interactions, how our body changes and transforms as we age. And then we think about mobility, keeping people independent and upright. So independence is the big key for geriatrics. What happens is when I see patients in my clinic, now I'm seeing generally elders. And by this time, as you stated, my patients are possibly on insulin at this point or already experiencing some cognitive deficits or some of the cardiovascular complications of their diabetes diagnosis. And so it gets a little bit challenging and trying to control for all of those factors and then really help those individuals have the best quality of life and the best health span. My focus now has been on the younger individuals who have new diabetes diagnoses or who have like pre-diabetes of insulin resistance, and how can we think about addressing that, especially if you know your family history in your second, third, fourth decade of life, so that by the time you're my patient, then we have a lot more room to work with. So I think there's a psychosocial issue here, and I think there's definitely a medical issue here. So I'm very excited to talk about all of that, but we know that diabetes increases your risk of dementia. Mm-hmm. That is one of the main risk factors. In 2023, there was another article, a big Cochrane review, that identified 14 risk factors. And I added one more to that, sleep apnea. So I have 15 that And diabetes is one of those. Lowering LDL cholesterol is one of those. Vision loss is one of those. Hearing loss is one of those. Hypertension is one of those. And how much are all of those things related to diabetes? And
right. So I mentioned 2 and there are 15. So,
yes.
So I was just at the tip of the iceberg. That's awesome. It's not, but it's so interesting and it speaks to that dynamic. And I have noticed exactly what you said, that in people, especially sometimes in healthcare providers, but mostly in people that I talk to, there is such a tendency to silo this one thing and not understand how everything is interconnected. When you've noticed that one of your patients is complaining about one symptom, but you understand that it's also tied to visceral fat, cholesterol levels, their blood pressure, how do you have that conversation with people, or what would you like for them to understand?
I approach health. I created this health framework, and I think it's just over the years of practicing geriatrics and then now lifestyle medicine, even more so the last few years. But I call it the health framework. And I think patient education is key, and helping my patients really engage and be empowered in their journey. And also not just like telling them medicine or this is how things should be, letting them take the lead on what matters to them. So I always start with like, okay, what really matters to you? And I sit with my patients. My first visit with my patients is about 2.5 to 3 hours long. And people are like, what do you do? And I'm like, it's not even enough time. Trust me, it really isn't. But I educate my patients, like, this is how your body is physiologically changing as you're aging. Then I cover those 5 M's, the matters, the mind, the medications, the medical problems, the mobility. Then I go into teaching them about energy. So this health framework, health is an acronym. The E is for energy, and we talk about energy-dependent disease processes from a cellular state to disease-dependent. And what are those? Those are cardiac, metabolic, cancer, cognitive disorders, and how those are related. Then once I've educated about that, we talk about, all right, now what helps us to prevent these diseases and what helps us really age better? We talk about activity, and I'm like, I don't mean for you to go to the gym. That's not what I'm saying. I'm talking about capacity and reserve, because if we focus on keeping you active, doing the things that you love, and focusing on what type of reserve you want and what type of capacity you need to have so that you can remain independent, then I think I'm meeting my goal for you, and I think you will be able to follow along. We talk about the L, which is the lifestyle medicine factors. So then I'm educating my patients on sleep, on social engagement, on abstaining from harmful substances, nutrition, and exercise, and then mental health. And the T is for transformation. So we talk about that. We need to adapt as we transform through our life. And diabetes is a disease that really not only changes despite the treatments that are offered, but there are metabolic changes that continue to happen regardless of how controlled our blood sugars are. It's just the disease process, and helping them through that guilt. Also, like, don't feel guilty. Sometimes you have very little control over what's happening, but let's make adaptations to keep you independent. And then the H is for our habits. And I talk about drift when it comes to that with my patients. Like, what has caused you to maybe drift? They're like, what do you mean drift? I'm like, okay, so we're on this path. We exercise every day, or we eat this way, a certain way. And then all of a sudden we're not. And I guess I'm, in a way, thankful that I've experienced some health issues myself, so I can use that as an example to illustrate that I am not perfect. You know, I had both of my hips replaced a year and 2 months ago, but that really changed. It caused me to drift from what I'm normally able to do. And the question is then, how do we incrementally reset? What becomes our reset technique? And if we can incrementally reset, and that effect is compounded so that we can come back and follow this path of, again, staying healthy and having a good health span despite the chronic disease process that's going on. and also ensuring that our expectations are reasonable. Like, okay, now I've made this change and this is a part of my lifestyle. What is the next change that I'm going to make? So I see my patients not just for their first visit, that's like the 2.5, 3 hours long, but I normally see them quarterly for another hour visit. I see them in between when they're sick. But that quarterly visit allows us to go back through all of those things and with their goals in mind. And we make changes. And some of those are medical changes and some of those are psychosocial changes. But I think that is the type of support people need, not just going to the doctor and being given a prescription and not understand what's actually going on.
Absolutely. Now, when you talk about your model of care that you provide your patients, I'm hearing a very long initial visit, a visit that's 4 times almost longer than the average primary care physician visit with patients, and more follow-up in general. So most of patients over age 65, I'm guessing, would have Medicare. So how is your patient different or the same as the primary care physician's patient, and how do you keep the doors open, so to speak? Like, how are you in a for-profit healthcare system, how are you able to manage that you get the time that you want and really the time that other physicians would like to have with patients?
This is a great question. Before I started my medical practice, so I am a private practice owner, I was a program director for geriatrics fellowship, and I worked under the auspice of a huge medical system where I was told, you have this much time with your patients. Every patient was worth a value unit. And the way I coded my visits, and patients essentially became what is valuable to the system and how can you bill. And as a geriatricians think a lot of medicine and a lot of education. So we're not really valued as much within the medical system, even though I think we help prevent hospitalizations. We help promote independence. We help prevent institutionalization or delay institutionalization into a nursing home. We help caregivers keep loved ones with dementia at home. We help people change and transform their lifestyles so that they are feeling healthier. But unfortunately, hospital systems don't value that because they don't.
Because if you prevent something from happening, nothing happens. And how do you measure nothing? It's exactly. A lot harder to measure.
And then also procedural medicine is right now what is valued. My gastroenterology colleagues, they're highly valued because it's the more colonoscopies, the more money you generate. So my practice is actually a small practice. But what I thought about, and I started the practice with one of the fellows that I taught, Dr. Blaney. She's lovely. And this is our 5th year in practice, and we're thriving and
Congrats.
We're growing. I know,
That's awesome.
It's great. But we thought,
fantastic.
And it doesn't actually cost that much when you think about it in the grand scheme of things. But I started a concierge model in that I charge our patients a fee annually. And that allows me to spend that time with them. It also allows me to visit them in the hospital and advocate for them there. It allows me to make a house call, and I walk with them till the very end, from the moment they join the practice until the last breath that they take. They are mine, and I have that responsibility to my patients. And they're not just patients, they become my family. So I go to bat for them and talk to specialists. But the cost of one night in the hospital, in the medical floor, it's about $3,000. So when I tell them, I'm like, okay, if that's one night in the hospital, what if I can prevent that one night of hospitalization? Is that then worth your annual fee? And a lot of them think that, yes, it is worth that because they're getting all of that time. And the other, I think, misconception is we become physicians, but attorneys charge hundreds of dollars an hour. We just recently had hired an attorney. I'm like, well, what makes them worth $300 an hour? I cost a fraction of that. And I'm giving you additional care. And it's not hype. This is sound evidence-based medicine. You're not spending thousands of dollars on supplements or medicine that is not backed by science. You are getting a real physician. So my patients find that this is valuable and worth it. And we are booked out. I don't have any appointment slots available until October. And I'm also willing to see patients on like an assessment base, so completing a geriatric assessment, or if they're not able to continue to see us on an annual basis, where I can write up an assessment and give their primary care providers recommendations, like this is something that you can follow. And it works. I also thought, well, how do I give back? How do I give back to people who cannot do this? And how can they advocate for themselves? Which also prompted me to start the blog that I started. It's called geriacademy.com, and it's totally free. I don't advertise on it, but the blog posts are written for people who are not doctors, and they are written to be read within 3 to 7 minutes on various aging, metabolic, cognitive, cardiovascular. These are the topics that are discussed, and there's a search tool so people can go and type dementia, and it goes through, oh, these are the risk factors, or cholesterol. This is all you need to know about inflammatory markers, basic cholesterol, so they can take that to their doctors and advocate for themselves. So I've tried to create that. The model is not perfect, but I've found that it works for me, and I'm able to reach people. I can't reach everyone, but I know that the individuals I'm reaching, they're getting more out of it than they would have in the traditional model.
So
I
have a
know
question,
that is true also.
if it's okay. You've mentioned health span, and I think that's a buzzword now, starting to be more common, people understanding this. A lot of times, and I can, of course, speak to diabetes, there's this concept that kind of what's happening to me is almost appropriate for where I am in life, right? Upon a diagnosis, there's very much kind of just an acceptance of this unideal situation where we've heard a million times, this is just my life now. When you're talking about the health span of a population in their 70s, in their 80s, in their 90s, of course, you can go on any social media platform and you can see outliers, weird folks doing stuff, but that's not common. What is common for most? What is possible for most? Because I think a lot of times, if people start to become aware that there are lifestyle changes they can make, there are controls, things, behaviors they can adopt that would allow them to feel better and move better and all that kind of stuff. What are you seeing with the population of people that you work with that is creating an increasingly larger population of, let's just call it outliers, people behaving and feeling atypical in later life?
This is such a great question because I have the best example. And I want to talk about this. I had a patient who came to my office, 305 pounds at the time they came to my office, and type 2 diabetic, was on insulin, was having severe knee problems because of osteoarthritis, because they were just so obese, depressed, very depressed. Partner had passed away. And if you think about generationally, with most of when you think about people in their 7th, 8th decade of life, these individuals have had partners, if they're males, that generally did all the cooking and took care of that. So sometimes we have elders who don't know how to cook, who don't know how to read a label. And this person had lost their wife. And so over the 2 years after the loss of their wife, their diabetes was completely out of control. It wasn't perfect before, but it was completely out of control. They were seeing an endocrinologist. And when they came to me, I said, well, what do you want to do? Again, we started with what matters to you, and really wanted to be able to take walks, feel good, travel to see their daughters out of state, wanted a dog, but knew they couldn't have any of those things. And I said, okay, we are going to do this together. And we have right now amazing medications that can help. And some people are like, put them down. But no, these medications are meant for diabetics and they help. Mm-hmm. I started this patient on a low dose GLP-1. And the other thing I did was tell me what restaurants you like to eat out at, because this person was primarily just eating out. We looked through menus together and I said, you know what, don't eat this instead when you go out to eat. And then I said, I want you to start cooking and I am going to show you what you need to cook and how you need to cook it. And it is not that hard. And so for the next 3 months, while the patient went to the grocery store, I said, call me every time you're at the grocery store. And it was a little FaceTime. I said, we are going to read food labels together. And we did. Started to read food labels and started to learn how to cook to make sure they had a balanced diet, good proteins, unsaturated fatty acids, soluble fiber. People are like, oh, carbs are terrible. I'm like, well, not every carb is the same. The carb you get from kale is definitely not the carb you get from Wonder Bread. So they ended up over 2 years, they went down to 240 pounds. So after 2 years, this person's A1C was controlled. We came off of their blood pressure medication, so they had no evidence of hypertension, and their cholesterol controlled. We kept them on their statin because of their diabetes, but lowered the dose just to make sure the LDL was controlled. Knee pain had improved, ended up getting a dog that they wanted. We're walking with their dog. And one of the jokes, I was on the phone with him one time, just called to go over some lab values. And he said, I'm that person everyone can't stand in the grocery store because I'm like reading every food label now. And I said, well, but this is amazing. So I missed my patient because he ended up moving down south, living near the kids, with the dog. And it was so transformational. It was incredible. And those are the cases that keep going, that keep me so excited about treating patients. And not all of my patients are diabetics, but I also have patients who have cognitive dysfunction, and they do that work where they are doing like cognitive rehab. We put them on a mind diet, they start to exercise, and their cognitive status improves. And then we also use those amyloid targeted treatments, the new medications used for dementia, but not everyone is a candidate because some people cannot use those medications because of their genetic profile. But it doesn't mean that we cannot do better. And I explained to him, like, Mother Nature wants to kill us off. And that's okay. But we don't need to decline and die. We can slam into the wall and die. We can live the best version of ourselves. And then and this is my goal. I'm like, I'm going to slam into the wall. I do not want to ease into death. And this is why when
do
everyone's
not go gently into that good night.
Yeah.
Yeah, no.
Rage against the dying of the light.
Exactly. There's no reason for us to ease into death. And I love David Sinclair's book, Lifespan. But then the more I started to read it, I was like, okay, yeah, but I'm a geriatrician and I'm all about quality of life. If I live to 80 and not 90, but I'm active and independent, that is what I want. So I'm going to focus on health span. And I think that's why this shift is also occurring.
Yes, I can identify with that very much. I have a paternal grandmother who passed away at 86 or 7. I have another paternal grandmother that passed away at 98. Another maternal grandmother still living at 97. And my other maternal grandmother passed away at 95. So I have a very good idea that I'm going to live so many years, but I don't want to live some of those years the way I saw 2 out of my 4, really 3 out of my 4 grandmothers or great grandmothers live those years. One was in a nursing home with bed sores and ulcers and lived for like 5 years in that condition. And I do want to talk about that some in a bit with you, because I know you talked about different stages of dementia. And when I heard you talk about that, I definitely have noticed teaching automated insulin delivery systems to people who were probably in late stage 2, based on what you described. And when you said they had, like, they're adults, of course, but their ability to learn new things was around age 3 to 5. And I'm like, that explains so much because it's like, push here, do that, and then that. And it was challenging for some people. And I was like, but there's pictures and there's a step by step. But when I heard you say that, I was like, oh, okay. And many of these people live alone, and it makes such a difference in teaching more complicated regimens for blood sugar control if there's a support person there who is a second set of eyes and ears who can remind them of things that they might miss and follow up with me or their doctor about what they are to do in certain situations. So I don't know if there's a question in that, but one thing that stood out to me when you talked about this concierge style medicine, I figured that had to be what it was given healthcare reimbursement and such. But that's very similar to what we do at Empowered Diabetes. And it is such a difference because I think you always have a case study or two, or several people who you think, what if they didn't have this support? What if they were up against this situation and didn't have that support? What would have happened? What would have become of them? And I've seen just life-changing things happen with so many people, and I know you have as well. And so I also would like to know, with your gentleman who lost 65 pounds, why not telehealth? And why not, since it's concierge, why not more remote stuff so that he could keep that access to you? And I also want to talk about work-life balance.
Sure. Well, actually what I did was, when he moved down, I found a concierge doctor. I did my research, found one, and we met to make sure this was the person that they wanted. And they still have my cell phone. So the relationship I develop with my patients is very unique because we are so intimately bound with each other. I get to know people, I think, at their core. And they also get to know me. They see my flaws. And non-traditionally, I let people know that, I am flawed. I have weaknesses. The other day
You mean you're human?
Sorry. I'm human. We have a little chocolate basket. And we had a very stressful conversation on the phone about someone who was really sick. And I was just feeling really sad. So I go to the chocolate basket, and as I'm reaching in there, I had one piece, and I go reach in there to get the other one, and my nurse came and slapped my hand away, come on, get a hold of yourself. But but I tell people, I'm like, we have to still experience life. But for this particular patient, I told them that you can call me anytime you want. I did want them to have a physician that they were able to see. And for a while, we were having phone conversations until they really trusted the doc that they were seeing. But we both found this doctor together, and we both were able to check off all the boxes to make sure they were going to take care of my patient in the same way. Mm-hmm. On the other hand, I have patients I have one who's moved to Colorado to be close to their child, and their child, they still fly back to see me, and they have a great doctor. I'm like, why are you doing this? But I'm still there to support them when they need to talk to me. And I do telehealth visits, not just with my patients, but also with caregivers. So sometimes they might have a family member who's living away and needing some caregiver support in that sense, or they need education on stages of dementia. Today, the visit that I made was with family. It wasn't really with my patient, so that they could understand the disease process and the changes that were taking place, so I could reassure the family. Those are things Medicare doesn't pay for. They don't pay for a routine visit. They don't pay for the education that comes with the routine things. They pay for sick care. Again, this is where the concierge model has helped. And my patients, I've had some who joined the practice, and I always say, just give me 6 months. If you decide it's not for you, that's fine. I will give you all of my notes to your previous provider. I will reach out to your previous provider and give them guidance on what I think should continue to happen with my geriatrics expertise. But most stay.
I can see why they would. Yeah. When you said that insurance, especially a lot of the health plans under the big Medicare HMOs and such, cover sick care instead of well care. I know with diabetes, because that's my little bucket here, they will cover for an initial assessment with education, and then everything is pretty much relegated to group. And if you have diabetes and kidney disease or something like that, you can often do MNT or medical nutrition therapy on top of that. But it is still very lacking. And I can say, as someone who was in a role under a diabetes self-management care and education training group that was endorsed by the American Diabetes Association, and we followed the little protocol stuff, it always felt lacking in that personal touch, in that ability to really understand the individual and their unique challenges, what motivates them, what their why is, what their identity as a person is. All of those things are missing from group training. And there's a lot of value to be done in group for the community for different things. But it's very hard to jump into the things that really motivate and change behavior. Is part of that why you, did you also have that recognition to move into more concierge medicine? Or what was your primary driver to do this?
I think my primary driver was frustration with our system. Yes. Mm-hmm. I would meet with for our quarterly meetings, and it was never like, oh, great, these are the ways that you guys are helping touch people's lives. It was more, oh, you haven't met your scores yet. Or one example was, they were like, you're not, and this isn't diabetic related, but one example was, you're not evaluating patients for depression. That's one of our meaningful use scores. And so we're not getting reimbursed. And I was like, that doesn't make any sense. I evaluate everyone for depression. You read my notes, that's in there. And what I found out was that what they wanted me to do was administer the PHQ-9, performative inside the EMR, the electronic medical record system. But what I explained to them was, well, can I just explain to you that most of my patients who have cognitive deficits, many of them may not comprehend the PHQ-9, so you're going to get a false result. And so I am administering the geriatric depression score, which you do not have in the EMR. You should have it. But that led to this big discussion, a research project that I did with my fellows, and we found out 40% of patients who had mild dementia did not comprehend the PHQ-9. So ultimately, the health system placed the geriatric depression screen inside the EMR, and they agreed with me. And this was also after I presented the data as a poster at the American Geriatric Society meeting. Like, hey, we really have to think about individuals. But the same thing goes with, yes, group sessions are awesome. And I also send people for diabetic education, but I tell them, once you go, I want you to come back and talk to me. And we go through what they learned, because how many times do we as individuals who are in that space miss things and not, Absolutely. We have to repeat the education and understand the education and help people understand, okay, what does this actually mean? This allotment of carbohydrate. What does this actually mean when we think about this? And then what does this actually mean as far as your kidney function goes and your protein intake goes? Because again, another big fad is the high protein. Well, we have to treat our patients as individuals. What if someone has chronic kidney disease?
Absolutely.
Then those recommendations are going to be different. So I love my diabetic educators in town. We send people for diabetic education. And I work with the large healthcare system in town. I send them there, but I always say, come back, let's go over that visit. Then it's another hour with me. And once they have the diabetic education, they can always go back, but I have to have that continued education and reinforcement and motivation so that they can stay on track.
I think people need to hear something 12 times to really commit it as a fact in their mind, they know it to be true. And then I'm thinking someone with mild dementia, that 12 could easily turn into 20 or more, or finding a way to attach it to something else that they already understand to be true. And maybe they don't fully understand it, but they get it built into something that works for them. And that's key, that they can just repeat those habits and get those habits established. Wow.
Remember, the other thing that we do that a lot of physicians are not aware of, but I think as a geriatrician, I'm aware of this. And having done a master's in gerontology, that whole psychosocial piece was ingrained in me before I became a doctor. But we have care navigators all over the country, geriatric care navigators. I send referrals to geriatric care navigators who can sit with the patient, go to their home, and see what their needs are. And sometimes
it's amazing.
Right. That sometimes their needs are medication management. Now, when we think about independence and functionality, we have our activities of daily living. And those things are bathing, feeding ourselves, mobility, grooming, toileting. If we have problems with those, then yes, we may need to be in a facility or we may need more care. But if it's only our instrumental activities of daily living that are lacking, like medication management, paying our bills, purchasing groceries, preparing meals, if there are resources that can help ensure those things are in place, then we can still live at home independently. And how cool would that be? So I think one important factor for your listeners is Google geriatric care navigators. And they can also help with transition planning as we change, and like lifestyle planning. They can help with living wills. They can help with end of life planning.
Okay.
Which is very helpful.
When you say this, I think of someone very dear to me who is caring for her husband with Alzheimer's dementia, very severe. And they're in a retirement community, but it's essentially very, very independent living. And she is struggling. She has been struggling for years and has not really been able to get him into a higher level facility so that she can have a life that is not caretaker 24/7. What would you recommend for this individual? Because she also has diabetes, which is how I know her. So she's struggling with caring for herself, plus a lot of care needed for her husband. And the guilt that goes along with, and the children, and having the conversation with them about who don't always visit that often and they haven't seen the progression of this. And she's navigated through that at this point, but I think maybe you could add to some of what that's like for people.
Yeah, as a program director, we ran a little research study. We looked at caregiver burden, and what we found was that spouses have their resilience is a lot more, and they are less burdened actually than adult children, which was incredible because those spouses are generally elders. They are generally also dealing with chronic disease burden, but yet somehow they get involved in this caregiving role and then they neglect themselves. And we have cases where the caregiver, I think the statistic is like 4 out of 10 caregivers die before the person that they are caring for.
Yeah.
And then what happens? So on the blog, there are some caregiver posts too, if your individual's interested to look at those. I normally sit down with my caregivers and I tell them this is not a one-person job. So they need to know that from the get-go. And guilt comes with it. Am I helping enough? Am I putting enough time into it? The empathy and the compassion that we extend to our loved one, if a caregiver extends just a fraction of that to themselves, that will go a long way. So I have that conversation with them. And I say, okay, we need to sit down, and I sit with them and I say, where is your circle of support? Let's talk about your circle of support. Who are the individuals that you can rely on that can support you, whether that is a paid individual or whether that is a family member or a friend. And then we make a list of the areas where they need support in. So I have a caregiver who very resistant for a while. The loved one was up all night, and this caregiver was just exhausted during the day, has her own medical problems and needs rest. So I finally convinced her to get someone to just come to their home, and while she sleeps there, this person can be awake just 3 nights a week. So our conversation then shifted and pivoted, and she was like, oh my gosh, like I have so much more energy and I can take care of myself. And then sometimes churches have volunteers that will come in, depending on the degree, the level of dementia, the stage of dementia. Sometimes people are qualified for palliative care. This is not hospice. And so palliative care group, usually these are through the hospice organizations, can come in and assess and see what that individual needs, even if that means it might be a provider that comes and does a physical examination and sees the patient rather than the patient having to go to the doctor's office, because some people are homebound. That will reduce some of the burden for the caregiver. But reducing caregiver burden is also done incrementally. We never know what the load is until we break it apart. And I think that is the first step. And then thinking about their role and their mission and how their caregiving role changes as the loved one they're caring for changes. So getting ahead of that is paramount. I recently took on a patient because I was taking care of their partner. And we thought the easiest way would be, and they live a little further away, we thought the easiest way would be that I take care of both of them so that I can just make house calls so that she doesn't have to try to put the loved one in a car because they tried to escape. They tried to leave the car as the car was moving. So, but
I was just like, wow.
Yeah.
Sorry.
Sometimes caregivers don't speak up and they're suffering silently. And so that is an ICD-10 code, caregiver difficulties. Doctors can talk about that. They often don't.
Good.
And as a medical community, we've definitely failed our caregivers. We're not putting enough resources into focusing on our caregivers where we should, because if our caregivers aren't taken care of, then our patients are not taken care of. And I guess I'll make one more comment there. Wouldn't that save the system a lot more money? Shouldn't they think of it that way if they're really so money driven?
Yes, that question, not that specific question, but this question of like, why is prevention not focused on more? And like, I remember when physical education was taken out of schools. I remember when nutrition education wasn't the focus. It was all about hitting certain test scores. And if you're out playing at recess, you can't be in the classroom studying, yet the research supported that playtime for better focus and memory and cognition. And I was just so curious when these changes were made, like who is allowing this to happen? And here we are 18, 20 years later, really feeling the effects of what I think many of us saw would be problems, if not immediately, absolutely down the line. And now we're here and so many people are like, how did we get here? It's red food dye. It's like, no, like there are a lot of things that happened that led us to where we are now, the least of which is red food dye. And so I love that you changed within your own healthcare system what they use for the dementia assessment. And I think it has to be more grassroots type change, more education. But what do you see as being some steps to take to get us out of a lot of the holes that we've dug? And by we, I don't mean, no, I'm just kidding.
Well, it's somehow we're all in this together.
Right,
we
are.
I have two older daughters that are like athletes, and they are in their athletic things like 10 to 20 hours a week. So I'm like, they're good. But my youngest daughter, she's ADHD. I have ADHD. But she needs physical movement. And she was getting in so much trouble at school. And I took her out of the traditional school model. The school she's at now, they focus on outdoor physical activity. They're in a creek all day. And what I noticed was her testing is now on grade level when she was suffering before, because the school still measures based on what the state standards are. And so I was like, oh my gosh, this is amazing. But she's having one-on-one teaching, and this is still a public school. And so
that's fantastic.
The themes are different, and they're focusing on if you need to move, you get up and move. They play outside. They have a full recess. They're outside like 45 minutes. They eat lunch outside. And yes, she's actually academically performing so much better. So to your point, you're absolutely right. And think about the teenage diabetes rates right now, type 2 diabetes, obesity, because we're not teaching our kids how to eat properly. We are so busy now. We're not taking the time to actually cook simple meals. And again, grassroots efforts are so important, but I'm constantly talking to my children about proper nutrition. And I think it's really like trickled down, because if my 13-year-old is not at the gymnastics gym, she'll come to the gym with me. They're thinking about, we were talking about, she's like, I am a vegetarian now. I'm like, okay, that's fine. But we need to talk about like protein intake, and we need to talk about micronutrients. And so she's eating the things that I am telling her that she needs to eat, but where did that education go? I think that's probably more practical life education than our math scores and our English scores. And I think we turn out just fine. I turned out just fine, not having that testing. I'm fine. Most of us as adults who had physical education at school and who had that ability to play outside, we're doing well. So why are we changing the things that worked so well for us? I don't know. But I agree with you. I think we just need some good grassroots efforts, and we need to speak up. Unfortunately, like, everything is so political that if you think it's one thing, everyone's like going to
And
But I
this
tell you,
leads to my favorite part of the show, which is every time we have a provider on here, I really like to ask policy questions, because in general, providers aren't making policy. And I think that's probably not ideal. People that are most qualified to make decisions from a patient care standpoint that are really going to move the needle are often not involved or not ultimately crafting the policies that we just talked about.
Yeah. And I think what you're asking is, like, I took a course in healthcare administration, and it was very different. It was more business, more accounting. It was not medical. It was business.
Well, this kind of gets to what I'm talking about. So again, coming from a military background, I almost have grown up in socialized medicine, but the mission's different, right? When you're talking about hospital administration, what we're talking about is this is a business. It has to run. I have to be cash flow positive every single month to keep the doors open and all that kind of stuff. In a military hospital, they aren't worried about getting money. So somebody at echelons above reality is, but the physicians
hospitals do care about the bottom line. And
the physicians in a military hospital, their mission is to make sure that there are as many deployable individuals as humanly possible. So there's the patients, if we want to call it that, it's not a one-to-one, but the people that particular provider is responsible for, his job is to make sure that they can deploy. If that soldier has a bad tooth, as silly as this sounds, I can't send this person across the planet to do whatever it is that they're going to do because they have a tooth that would impair their ability to effectively engage the enemy. So as silly as that sounds, that provider gets really worked up about you being, they call it dental cat 4, you're non-deployable because you got bad teeth or whatever. We will jump through all kind of hoops to get you fully functional to be able to fulfill your mission. As it relates to geriatrics, we're talking about a population that from a society standpoint kind of doesn't have a mission. You're still around. If you've done well, you've got maybe enough money to kind of coast you through retirement. But we as a society are not focused on encouraging and really almost demanding purpose of our individuals, of our people in later life. Kind of a long way to say that all of the problems that you're talking about it's really a problem of but money. that is the reason.
I think there was a lot of things tied into that because you talked about purpose with retirement and aging. And also, like, there was a lot tied into that.
But what I'm getting at is this, and this is really more a question for you. Let's say tomorrow, for whatever reason, you're put in a position where you can craft policy for our nation, whatever that is, to offset the costs of a population that is becoming increasingly sick, increasingly less capable of caring for themselves, less capable mentally, physically, all this other kind of stuff. There is a societal cost. And if society truly had to pay that cost, if the ultimate dollars attached to that care was truly on the taxpayer,
it is.
Well, it is and it isn't. If we truly were going to, okay, let's reduce costs through preventative care, what does that look like? What do we need to do as a nation to not just care for our elders better, but to truly save a ton of money on things that if we just got maybe addressed it a little bit earlier, or if we started to standardize some practices, what would you do?
Well, I'm very opinionated here. When I was in the hospital system, I was getting involved with hospital administration and some hospital administrative policies. I was getting frustrated, and I realized, well, either I don't know what I'm talking about or how I'm thinking because I'm a physician and I know nothing about business, or they're like not telling me what they should be, or they're lying to me. Lie is a big word. I went home one day and I told my husband, who's
Not
also
being
a
fully
physician.
transparent, let's say.
Yeah. I told my husband, I said, I'm going to go to business school. And he's a physician too. He said, I'll do it with you. So we did. We went for 3 years.
I love
we
it.
got an MBA with a healthcare administration focus, and our 5 a.m. wake up to study an hour, and our date nights, we studied. The best thing is when a physician who has a little OCD goes to business school, they do really well. It became very competitive between us in the home. And then my accounting professor asked me if I wanted to go into a PhD for accounting. I'm like, no, I'm a physician. I'm just trying to learn the business of this. Well, what I started to think about, and I think it helped me craft this business plan, what I thought about is, okay, let's go back to the insurance companies. They're the ones that don't want to pay. They're the ones that are negotiating with the hospital systems. So what if insurance companies start to negotiate with the physicians? Because physicians know what they want for their patients. And what if a patient had the opportunity to say, this is the physician that I want? Like in this kind of model, yes, we will pay this concierge fee because we know that this could potentially prevent even one night in the hospital. And most elders are not hospitalized for one night. No, they're hospitalized multiple nights. So that costs a lot of money. And then the readmissions, and then thinking about every test that goes into that hospitalization, and the lies and transparency and how much a procedure costs, because one hospital will charge this much and one hospital will charge that much, and then what then Medicare is reimbursing. It's a messy system. But what if we make it simple and say, you know what, you can choose your primary care doctor, you can choose your geriatrician. There are not very many of us, but you can choose it in a way where they may not be taking care of as many patients, but they're doing a good job, and they are preventing hospitalizations. They are making responsible decisions. They are supporting their patients, and these people have a better quality of life. So that was one approach. And then if you think about large hospital systems, there is no reason. We know of a CEO in our state. It's like $21 million. This was his annual salary, and yet they're making pay cuts to reduce the number of social workers who are willing to help people with cancer navigation because they don't have the money. Then how does this man have the money? So if you're in it, and this is a nonprofit system. So this is a nonprofit system. And sometimes people are like, oh, well, this is a for-profit hospital. I'm like, there's no difference. The only difference is the way that they register themselves and the taxation. So realistically, that nonprofit system is just as bad as the for-profit system. Let's not confuse those words as to they're doing good for the community. But maybe, and the best systems, the best hospital systems are ran by physicians. Now, I'm not saying physicians should run on hospitals, because if you're a physician that does not have business expertise, you shouldn't be an administrator. But if you're an administrator who has never taken care of a patient, you have no right making decisions. Like no right. And I am
I feel like I'm in church right now.
I am like just so passionate about that statement. And there have been so many colleagues that I've had who have business experience and who are physicians. Oh my gosh, they make great decisions. And I think the system benefits. But we need to start that discussion.
So I'm going to throw a little wrinkle in here. What you're advocating for, if done well and at scale, would result in less hospitalization, would result in less billable events for that hospital. So how do we responsibly shift the existing medical infrastructure to, even, I guess, from a billing standpoint, how do we prioritize making the things that ultimately result in better patient outcomes, better patient health? How do we shift focus towards you can be financially compensated for that versus a test or a machine or a panel or whatever that is? Because right now, the financial incentivization, I think that's a word, we are financially incentivized to do exactly what we're doing right now, to perpetuate this forever, and it's not working.
The simple question is that this is healthcare. This is our health. This isn't like software. This isn't this isn't tech. This isn't stock markets. Well, it is, and the other way because they are publicly traded. But this is healthcare. This is like human health, where I think we need to think about, right, we should adequately compensate the people who are actually doing the work. And we need to stop thinking about how do we grow into these big monopolies and dominate. Because one other problem that is occurring is these smaller hospitals that are serving small communities are closing. Because most people who live in rural America have Medicare, Medicaid, and those small hospitals end up closing because those patients are not, their insurance plans are not reimbursing the hospitals enough. So a large system purchases the hospital, and then now you have individuals living in these big urban cities who have private insurance, and so the hospital makes more money. Now they're making individuals who need to deliver babies, individuals who have strokes, individuals with heart attacks have to go to the big system, have to travel in order to get the care they want. So bottom line, I think there needs to be some government policy involvement to shift back and say, no, this is actually healthcare. It shouldn't necessarily be a business. The business part of healthcare should be that the individuals who are providing the care and who are doing the work, they should be adequately compensated because they're doing work. They're the ones on the front lines. And we need to start taking back, like I do think that the military approach in terms of the socialization of healthcare, in that aspect, I completely agree with it. But that will allow the individuals who are doing the work to get compensated. And our large businessmen and women who are in it to make $21 million, they need to maybe shift to another industry. They should shift to another industry because we're talking about people's lives here.
Wow. Yeah.
No one's going to hire me. I'm just saying I'm good. It's okay.
That's why you had to start your own business. Oh, well.
So I had to start my own thing.
That's fantastic. I love that. I love that so much. Yes, because it is a problem when you get certain groups that are reimbursing doctors if they check the box on doing certain things, and you're only going to get reimbursed this much if your patient's A1C is this, and this much if their A1C is this, never minding the fact that they went from a 12 to an 8. That is a huge change for that patient, and maybe an 8 is as low as you're going to get their A1C without the risk of hypoglycemia because of their mental status or their confounding factors in their life. And then when you have the pharmacy benefit managers owning the large hospitals, owning the insurance companies, I just don't understand. We have antitrust laws. We have these things to break up monopolies, yet it's alive and well in the U.S. healthcare system.
I agree with you. I totally share your feelings here. And I think, why aren't we teaching people who maybe are those pre-diabetics? Why aren't we getting them, getting more aggressive there and helping them so they don't become
reimbursement for that.
Right, there's no insurance reimbursement. Yeah. But when I get an A1C and it is 5.8 in a 65-year-old, I'm like, we need to get ahead of this.
Preach.
Where in the traditional setting, it's not like, oh, it's fine until you have diabetes. And then why is it that, if someone has metabolic syndrome, I am losing my mind here. Someone has metabolic syndrome and they have an elevated A1C, not quite diabetic, they're morbidly obese, they have high cholesterol, hypertension, but because they're not a diabetic, Medicare will not cover a GLP-1. And they have sleep apnea, so they're not getting oxygen to their brain.
Not even metformin.
Not even metformin. And I'm like,
easy as
what is happening here? Why are we not doing this?
Or seeing a dietitian. I had to add that plug-in to everything.
Absolutely. Or seeing a dietitian. Why are we not getting ahead of this? Because it is going to cost you. It is going to cost the American people a lot more money because we're paying taxes, and what is going to happen is to take care of that person once they are a diabetic. And not only the blood sugar
Or they have a heart
aspect.
attack or a stroke, which are
It's
even
the heart
more
attack,
likely.
it's the stroke, it's the dementia piece. If we know that there are 15 risk factors that can delay or prevent dementia by 40%, that is, think about 2 years of living in a nursing home and how much that costs the system. Because people have to spend down, get on Medicaid if they don't have the resources to be in a nursing facility.
I'm pretty sure that's at least 75 grand, what you just said.
It's somewhere between, and depending on assisted living in the country, somewhere between $50,000 to $120,000 a year, which if people have enough money to be in an assisted living, that money goes fast.
Yeah.
So it's just, I think a lot of it is completely greed driven. I have to say, even with our concierge practice, we could have grown more. I'm practically, again, the nature of my business is people move and people pass away, but we could have grown more. I just was like, no, I don't need to make more money. What I need to do is take really good care of the patients that I have. And I only see 150 patients in my panel. That is it. I am willing to do some assessments, but this allows me to be available. And then you had asked about, work-life balance. It allows me to have that work-life balance, because if I need to take my kids somewhere, I can take them somewhere and then I can come to the office. If I need to leave a little early, I can leave a little early and make a house call and then come back. So it gives me that flexibility. And when you have 150 patients versus most physicians who are taking care of 2,000 to 3,000 patients.
That's what I was going to say. You're like 10% the average physician.
Yeah. When a patient calls you, I'm not getting so many calls on the weekend. I'm getting 2 or 3, but they're really good. They're really good calls because I know the patient inside and out and I can give them quality feedback. It's not like, who are you again? I forgot.
Yeah. Yeah. And it's not that the primary care physician doesn't have these same calls on the weekend if they have hospital privileges. It's still happening, and it's happening for you less, and you know their situation right away. You don't have to get back to the chart and look in and check your notes. You know them intimately. Huge difference.
Exactly. And do you know, one of the other interesting things is the education programs, the residency programs in the country are run by large hospital systems. So H.E.A.L.T.H is one of the largest educators of residents. And one of the most fascinating things, and I have some medical students now and some residents, and I want them here so that they can see, oh, it doesn't have to be that way. But they educate them and train them to be a commodity. And they educate them that this is okay, this type of lifestyle is okay. And yet on the other end, they're like, well, why are physicians burning out? And why are physicians leaving medicine? And now I know one of the speakers was talking about, one of our politicians was talking about, we need to think about accepting people into medical school who are willing to stay in the field for 20, 25 years and who are not staying in the field. It's like, well, why don't you think they're staying in the field for 25 years?
Right.
We go into medicine to help people and to do a good thing, not to come home at night and think, who were these 30 patients that I saw today? And try to wrap your mind around what you did. Did you miss something? Did you do the right things? Did you finish your documentation so that it met Medicare requirements? And then staying up all night trying to catch up with that. I was up late last night, but it was cool because something had come up with a patient's care. And I called the patient on accident. So I just got so wrapped up in reading the new guidelines from the American College of Cardiology and the AHA that I lost track of time. But it was so fun because I was reading medicine, doing the thing that I love.
Isn't that true? It's such a difference when you have it, it's on your terms and you're empowered. Yes. You enjoy it. I've looked at glucose reports lying in bed before I go to sleep. Who does this chaos? And I'm having fun because it's a different setting and it's really being able to help people and it's easy and it's carefree, which is totally different than other settings where I'm like, oh, I have to chart on this and chart on that. And it's always right before the end of the session that the real meat and potatoes comes out about what they really need. And then you're behind schedule and then everyone's mad at you because you took the time with that person about what was really going to make a difference. And I didn't mean to interrupt you, but I was like, wow.
No, you're right. That interruption was great. You were absolutely right about that. So I picked up the phone, dialed the patient, and then I looked at the time and it was 10:30. I I'm like, oh, I hung up, and then I sent a text, and I'm like, I am so sorry. I know we had spoken earlier and we had one plan, but I just learned these the new guidelines just came out in March. And because I wanted to make sure, are there new guidelines out this year? So I have a different plan. We were talking on the phone, and my husband came in as he's working late this week, but it's like, what are you doing? I'm like, oh, I just wanted to talk to my patient about these things. And it's so meaningful. I don't know, that this job just fills my cup every single day. And it keeps me so content, where I don't feel like a burned out physician. So I can take care of my patients. We don't want burned out doctors. We don't want burned out social workers. We don't want burned out diabetic educators. We want people who go
And
every
I don't
day.
want the care from that burnt out person.
No.
It's not going to have the same quality at all.
It won't. So yeah, we need to make some big changes. Unfortunately, when doctors like me start to speak up, which I did, they try to shut us down. And so my only option at the time was either I go with the flow and just stay quiet, or I just build what I want and do it the way that I want to do it. And so that's what I did. And
one
it
is
has
very
worked
good for your
so
mental
well.
health, and the other one is devastating for it.
Yes.
Yeah.
Yeah.
Wow.
Well, Dr. Sharafsaleh, we really appreciate your time. You've given us a lot to think about, and hopefully we've given some folks that maybe are listening to this from a policy standpoint something to think about as well. If people want to find out more about you or your practice, where can they go to get more information?
Sure. So the blog post is easy. It's called Geri Academy, GERI, academy.com. People from all over the world read it. Easy blog post, easy information. People can message me there. I look for messages, I reply back. And my practice is goldenoakmedicine.com. It's in Asheville, North Carolina. Asheville is an interesting place. We all just do our own thing, and it works well for our practice, but everyone is very much of an individual here. So the community is pretty awesome. But really, yeah, the blog is available for anyone who's interested. And what's funny is I thought we were going to talk about like GLUT4 transport, insulin resistance. I know we shifted. And I was thinking today as I was coming on, I thought, I need to write a blog post this weekend on the actual mechanism of how insulin resistance and diabetes causes neuroinflammation. So I will put that up there, because I know we didn't discuss that.
Yes, no,
So
and
that
we
people
can
understand.
always, if you're open to it, I love talking to you. We have a podcast on brain insulin resistance. I would love your input and insight in this area. I think we can't talk about it enough. So independent of your blog, if you would be willing to come back, I would love to have you back.
Absolutely. It's such a big topic. It really is,
Yes.
especially with the landscape and how, like I said, we have young people now with type 2 diabetes that we did not have 30 years ago. And these individuals in 30 years are going to deal with the downstream neurologic cardiovascular effects of having continued elevated blood sugars. And we need to capture that and bring awareness to that, so that we're,
Yeah,
we're
because
not having...
younger people die from heart attacks because they've been obese their entire life. And I know you've seen this. And this is uncharted territory for the most part. And understanding what it's like for someone who has been obese since age 2, what their life looks like at 30 versus anything in the medical records and literature for anyone else up to that point. Oh, we're going to please come back so we can dive into that more. So much to talk about.
This is the first time our life expectancy is dropping.
Has gone down.
Why is it dropping? We have so many opportunities here. And it is all lifestyle driven.
Yes, we definitely are big lifestyle component people. And we have this podcast as our free way to reach people, same as you, it sounds like. So thank you so much from the bottom of my heart. I'm just so appreciative for your passion and your willingness to do something different to really reach people that need help. And it's a true physician heart and just human heart. Thank you.
Absolutely. And thank you both so much for letting me express my feelings about this topic.
Yeah,
Yes,
thank you for your time, and thank you for coming on the Diabetes Podcast.
My pleasure. Thank you.
Thanks for listening to the Diabetes Podcast.
If you haven't done so, please subscribe or follow the podcast to make sure that you get notified when new episodes drop. And until next time, take courage. You can do this, and we can help.